You're listening to the Sick and Good podcast. My name is Dustin Messick. I'm a registered dietitian nutritionist and a cancer survivor.
My name is Colin Goodwin. I'm a clinical psychologist and a cancer survivor. We're promoting wellness by having discussions on screening, treatment, and recovery throughout the cancer journey.
To find a balance between sick and good.
That during the cancer process, both can be true.
The Sick and Good podcast is for educational purposes only. The podcast is not intended to be a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified healthcare provider with any questions you may have regarding a medical condition or treatment and before undertaking a new healthcare regimen.
Jess Piper is a licensed clinical social worker, therapist, rural healthcare advocate, and entrepreneur. She has spent the majority of her career in oncology social work and is the co-founder of NaviCare, a telehealth service delivering comprehensive medical social work and supportive care to rural healthcare systems. Welcome to the podcast, Jessica. And I know that you prefer Jess, so I'll call you Jess throughout the rest of that. But what brought you into social work?
So what brought me to social work was that a couple of things brought me to social work. One was that grew up with, I'm one of 5 kids, and I grew up in a family that was very well versed in the healthcare system because 2 of my siblings were special needs. So that's really was my first kind of introduction into what that was like and what that is like to kind of need a lot of extra support and what support services actually are in the healthcare setting and how critical they can be and how they really do make a huge difference. And then the second part was that I was originally a DoD contractor, where I just kind of got bored of, you know, doing that whole thing. And then there were some major political shifts that happened, and it just really made me want to take the step forward to being that change that I wanted to see in the world. And so as a result, I just pursued my master's degree in social work. And then, really, when I was in social work, what I loved was, again, working in that medical system. It felt very familiar to me because, like I said, I had grown up in that whole world. And so it was really interesting to see how having that experience, even from childhood, could really mean that I could sit and talk and meet a lot of families who were just like my family and be what they needed, and I knew it because I knew what it was like to be on the other side. And so that was really what brought me into, in particular, and drew me to specifically medical social work, because social work has a very broad spectrum of different things. You can do tons of different things with it, but it was really the medical field that I felt comfortable with. And I also have a degree in biology, so I think that was also a really cool way of being able to use some of those skill sets, because in medical social work, you do have to have a degree of sort of medical terminology and understanding. And so I really liked being able to apply that knowledge as well. And so after that, I did some time working in the VA, and I worked in homeless outreach and healthcare for homeless veterans. And so that was basically getting veterans connected to healthcare. And then after that, I ended up out in Washington State in a very tiny rural area. Beautiful, absolutely beautiful, but an area that was very rich in natural resources. But when it came to, in particular, oncology resources, we were very, very limited. And it was really my first actual social work job, was an oncology social worker. And I just kind of fell in love with being able to do that work. And then also the uniqueness that it is when you're working in rural communities and in small uh, areas where you really are a lifeline. Like it's critical to be able to get, a patient transportation support to and from their treatment. It's a lifeline out there. And so being able to do that with such high stakes and also be able to apply some creative problem solving, that's really what I enjoy about the work
What
and
led you
really
to
enjoy
start
about working
NaviCare?
in the rural community. So NaviCare was really born out of the idea of being able to recognize that social work services were are critical, especially in these rural communities, and that what's also really unique about certain rural communities is the ability to attract social workers and other support services such as dietitians or triage nurses or nurse navigators, patient navigators. It's not common to have all of that in a rural healthcare setting, and it's so necessary and so needed. And a lot of the reasons why, and I saw this firsthand, was that you didn't have either, like, the cost of living was too substantial to be out there. So basically, like a social work salary, living out in Port Townsend, you couldn't find a home. So there was a housing crisis happening, plus also being able to just have talent, like recruit that talent there. That wasn't a thing either. It's everybody kind of graduates and then they stay in the bigger cities, but the people that really need the support are really out in these rural communities. And so I was really wanting to figure out a way that I could provide telehealth and social work as well as other support services to communities just like the one I was serving in Port Townsend. And so it just kind of struck me to, what if this looked bigger? Was essentially what I said, was like, what if we could do this on a larger scale or with other organizations such as the one that I'm working at? And that is where it kind of be got was born out of. And now we're able to provide some chronic care management to communities that would have never had access to it. We're able to write grants and things like that on behalf of these facilities that had never had somebody have the time to write the grant. Because if I was to paint the picture of
The one man
what it's
band.
like
Yeah.
working in rural
Yeah,
healthcare, if
yeah,
you've
I
ever
have.
seen have you ever seen the movie Mary Poppins? Yeah, yeah. And then you have Dick Van Dyke's character who he's out there playing the drums. Yes, the one man band. That is exactly what it is like. And you're wearing a million hats. You're jumping from one thing to the next. And it's exciting. And it's also really challenging because people don't have the time or the resources, like, to ask higher ups about things. It's no, like, you are it. So you kind of have to make it happen. And that's been really cool to see how beneficial being able to provide that support also to these healthcare systems has led to them being able to have transportation funds that they never had before, and things like that, all because of, seeing the need and building the support around it and being willing to be creative. So it feels good to know that being able to do that means somebody was actually able to access life-saving treatment. A gas card makes a difference.
Hey, Jess, you started to talk about just what it looks like for um, treating rural communities and what that looks like as far as rural healthcare in your practice. One thing you had touched on is just like the kind of the pivot to telehealth. Wanted to see if you could just maybe expand on what it looks like to then um, offer your services in rural communities, and that implementation of kind of pivoting to a more of a telehealth than modality.
Yeah, well, telehealth really became telehealth when back with the pandemic. And when I first was introduced to it, it was like, oh, it was like a fireworks went off. There were so many avenues that this could be used, because so many times I would run into issues where people could not get transportation to, let's say, Seattle, which, just to paint that picture for the folks in Port Townsend, that would be usually a 50-minute drive around the mountains, crossing over via ferry, and then navigating downtown Seattle to get to the bigger facilities there. And so that ended up being a huge challenge for a lot of folks. They just could not navigate that, and especially during the pandemic. And so being able to bring telehealth services and support to our community was. Oh, do we need to keep going? Okay, sorry. Um, but so being able to bring those services to the patients made a huge difference. And it first started with being able to teach people how to navigate my chart. So I spent some time setting up a program at the facility that would help us teach a lot of these patients how to use their my chart, how to log on to a telehealth appointment. Because we also in Port Townsend, we have one of the highest rates of, or not rates, but the highest age population. So majority of our population is significantly older than other parts of the state. And so what was interesting was to see how being able to access their my chart, access their doctors for telehealth, and just teaching them once or twice was a complete game changer. And so it made me realize that this could be done on a bigger scale with the right support. And there's some, to be quite honest, there are some things that still working out the kinks of the support side of it. Like, if there's paperwork that needs to be done, or, various things like that. But I think a lot of what's happened is moving supportive services more to telehealth has been really well adapted, because it's kind of like calling your friend. You get a phone call. Usually I'll call a little bit in the afternoon or the evenings, because for a lot of our folks, you know they're lonely. They may not have other people, so they really enjoy having those moments where they get to chat and just check in and talk about their day. And obviously I find ways to integrate some of that care navigation, or needs assessments, or some of the things that I typically do as a social worker. But I also am building relationships, and that is what I have learned is the most important thing. That with telehealth you can still build a relationship with people, even though you are thousands of miles away, and it's just about seeing them as a person. And in rural communities, I often would say, when I was in the working like in the clinic directly, I say, we care for the community we live in. And that you could see somebody who would come in and would be very, you know, anxious. They just got the diagnosis. It's maybe their first or second appointment. They haven't figured out the plan yet. So they're in that hurry up and wait phase, which is high anxiety. And one of my favorite things to do would be to come in, sit next to them, and say that phrase of, listen, we care for the community we live in. And 9 times out of 10, I would get, I feel that. that's what they would say in response is, I feel that. And that was it's such a powerful moment to know that, we could make that connection and then being able to expand it to other areas. Because it's true. It's That's what rural healthcare is all about, is being able to care for the community that you are in. And even though I'm in a telehealth setting, I still will look up what the weather is. I still will, find out some of the local lore of the area, so I can get and travel to there and get the vibe of what it's like. So I can build rapport with people based on that. Oh, yeah, that's a great place. So have you been to the Spruce Cruise? That's great. They got great burgers over there, and it's just things like that that we have kind of, moved away from in a lot of ways. But telehealth really allows me to kind of be more of that person centered care than I think other forms of telehealth or just healthcare has become in general.
I was going to say, like, you've got to be aware of the turf war in the Pacific Northwest between those werewolves and vampires, right?
Yes, exactly. And actually, Forks is part of one of the communities that we serve. It's one of those that are in that area. It's right around the mountain.
No, I'm so glad that I was able to make a Twilight reference. You know, um, one thing I was going to maybe comment on as well is like that. There's, I think, a new challenge with telehealth is maintaining a professionalism when it feels so personal. I think for me, there's some things that I want to then say, like, hey, make sure that you're treating this like you're seeing your primary care physician, because like you can't be driving or smoking or doing these things that are going to be not conducive to a therapeutic appointment.
Yeah, yeah, exactly. And there's moments where it can be challenging for sure. But at the same time, I also see it as there's sometimes some real benefits to it too. Like where I've seen it where I've had a patient who became very dysregulated, and their pet will come and sit on their lap, and it's kind of like you get to have pet therapy in a way that they couldn't ever do in a traditional clinic setting or a therapy office. So that's been really cool to see too, is how it it allows people to be a little bit more comfortable. And it's, recognizing that they're inviting you into their home on some level, and they'll always be like, oh, don't mind the mess. And I'll take my picture and I'll pan around and I'll be like, look at my desk, it's messy too. Like, it's just a great way to be in a space and in their environment and really get a feel for it. But yeah, it can certainly be challenging when you have some difficult behaviors that might come up, or it might feel too casual sometimes. But
Can you speak
fortunately, I
to what
haven't
it
run
was
into
like
that too
when
much. So.
patients began returning for care post pandemic? Was there a noticeable like influx?
Yeah, yeah, there certainly was. And I think really we're still in that space. Truly, I think what we really saw was a significant increase in later diagnosis. And with cancer care, obviously, as you all know, the time is of the essence. And later diagnosed folks tend to have much more complicated treatment regimens and, needing more complex care. And so, what we were really seeing, especially in certain types of cancers, uh, we were really seeing folks who needed, probably to come in maybe a year ago, coming in, with some pretty advanced cancers. And when you look at that and apply the rural healthcare lens, it's like looking and seeing this like tsunami coming at you because we have very limited resources. We have, limited space. We were also struggling at that time with it, which I think all healthcare systems experienced a lot of health, provider burnout, um, you know, had lower staffing numbers and all of those things. And I think just now, a lot of organizations are really starting to kind of get a little bit more back on their feet. But it really did. It totally came in, and it was just this huge influx of patients. And for a lot of folks and a lot of systems, it was a significant stress test that a lot of, especially in the rural community, did not, sustain sustain, but not because they didn't want to or were not able to. It was just the systems and the support that they needed was just not there, which is really what's led me to become more of an advocate for healthcare and kind of a rural healthcare, and really trying to raise the alarm bells of like, we need to do better, and we have opportunities, such as, the distribution of funding. Distribution of funding isn't, in terms of like research and grants and things like that, are not really factored in for our rural folks and in the rural community. And so, reaching out to organizations like the American Cancer Society. I have a great partner that I work with, that and who's really was there when I sent an email that was just like, because we experienced a chemo shortage, actually. So patients in our community were having to give up treatment. And this was one of those moments where it's like, it just hits you right in the heart, because we'd have patients who were stage 4, and they're like, you know give my treatment to someone else, and that's the reality of what were living with. And I had sent a letter to the American Cancer Society. I looked up somebody on LinkedIn. I was just determined to be like, we've got to do better.
You were sleuthing.
And yes, well, that's where my myriad of background jobs that I've had over the years has helped, is because like I just knew there was ways around this, or ways to at least let people know what was going on, because a lot of folks in our community were just left with no answers and no support, and that wasn't acceptable to me. And so did what we could to kind of build relationships with some of the bigger cancer centers and things like that. But it was really eye-opening of how inequitable it can be when it comes to if you get diagnosed with cancer in a rural community. Um, and I think that's just a product of the system, not a product of the person.
Hey, can you perhaps maybe expand on just some of these ethical considerations, or perhaps moral dilemmas that you've encountered while treating rural populations?
Yeah, there's been quite a few moments. Well, one, obviously, in social work, there's a big element of dual relationships. And it's really challenging when you live in a rural community to not have dual relationships, because, like I said, we care for the community we live in. And so it's like, that they may also be my neighbor. They may also be the person that I meet at the co-op or whatever it is. And so that sometimes can be a ethical thing you have to be aware of. But overall, some of the ethical and moral challenges have really come from, uh, just being able to get patients the care that they need, and being able to be that advocate. It's been really challenging to work on the social work side, because we used to be much more in that advocacy role. And, I remember I was advocating for a patient whose surgery kept getting delayed and delayed, and it was an issue with an insurance thing. And I was trying to call the big hospital that they needed to go to, and they said, well, they would have to just come in and talk with our person. And I was like, they can't, they physically cannot do that. And then I got a response of, well, we don't talk to social workers. And I just was like aghast by that. And I'm one of those people that when you tell me no, like I'm like, okay, let me go. I'm gonna go, like the bear in the woods, like over, around, through, whatever I can to do what I can for the people that need it, because I take it very personally of like they've they've put that trust in my hands, much like they put the trust in the oncologist's hands to pick out the treatment and to one that aligns with their goals. And so it's like when they put that trust in my hands, I take that very personally, because I see, my mom, I see my little sister who very much needed those services, and how hard that was on a family system. And it's like when you add that plus the fact that they're, in pain and they're struggling, how could you not? How could you not make this person feel like a person to, these bigger um, university systems and some of these larger hospital systems. So that's really what I've been trying to do from the advocacy role is be able to highlight that. And it comes with some challenges though too, because you kind of have to do a little bit of a dance, you know. Um, you don't want to kind of call anyone out by any means, but at the same time, there's moments where, for example, um, had a patient that uh, needed to get to one of the larger facilities that is in our area, and I was trying to work with the other social worker who was wonderful, but they have a lot more legality around their accessing care. So, like, a patient has to be seen first as part of their policy, has to be able to get to their appointment first before they can help them. And the challenge with that is that then that puts it back onto us in the rural communities that are lacking in resources to be able to get a patient to that first appointment before they can access some of the bigger, fancier, grants or support. So that's been quite the challenge of from a professional standpoint of navigating that, but also not letting your frustration around those systems show too much sometimes.
Literally having them get their foot in the door. I also like the comparison that of a bear that you're going to find a way, find a solution, over and around and through kind of thing, because it just kind of reminded me. It's like, okay, well, you kind of have to go mama bear at that point to then feel like you are protecting them in that advocacy role.
Yeah, absolutely. I joke because I will literally say that. I'll say to a patient, listen, my mama bear instincts have been activated, and we will get through this. And so it is kind of like a very protective mama bear role. um, but it doesn't always come with building relationships, but I try to as much as I can. But sometimes it can be really challenging, because at the end of the day, it really does lead to significant delays in care, and that, as we all know, leads to poor outcomes. And it shouldn't be like that. So I will keep being a mama bear around those things as much as I need to.
Still having to do that dance. I was thinking like, oh, God, is it like a line dance where like there's these rules you have to stay aligned to, and like never been a line dancer, but you get my point where it's like you have to follow along, right?
Right. Yeah. Well, and it's very eye opening when I have worked with some of the larger kind of urban facilities and things like that. Is just the disconnect between what it is really like out in these communities, and sometimes we'll see that when we get like the discharge plans or something like that. And it's like, that doesn't exist here. Like when they might have like a medical shelter a lot of times. So for people who are with housing issues, there's like a medical shelter that you can discharge patients to in a lot of larger cities might have these things. Rural facilities, we do not have those things. And so that's been challenges that we've encountered too. I remember one time we had a patient who had just finished, he had a head and neck cancer and had just completed a, I can't think of, I'm going to botch the terminology of it, but when they resect part of the
The thyroid?
throat, the
Oh,
throat, no, his throat, his actual throat. Um, and was discharged with a J tube and feeding, and then the DME company was refusing to send him his his DME because he lived in a tent. And they said he doesn't have a refrigerator, and I was like, yes, I know that, and he will starve, so it's just kind of, that's the kind of dance almost that you have to do sometimes, of like reminding people that there are people very much who live outside of the systems and the policies and all of these things, um, and reminding them that they're people, and we have to figure out a way to meet their needs too.
Can you speak to fragmented care and your efforts to create a task force for the urban and rural populations?
Yeah, so fragmented care is, just to kind of break it down in a rough way of what it actually is it's kind of when people may dip their toes into multiple kind of care systems throughout their cancer journey, or even just healthcare in general. So you see this really a lot in the rural communities because, for instance, like one of the hospitals I work with, they're just now getting a radiation center, but for a long time they didn't have that. So patients would have to go to another healthcare system in order to access radiation care. But what you'll usually see with cancer is that, you're not just seeing, you might be seeing a cardiologist, you might be seeing a pulmonologist, you might be seeing all of these other specialists on top of your oncologist, on top of your primary care. And it's just you'll see like all the baton getting passed to all these multiple different places. And what ends up happening in fragmented care is that the baton doesn't get passed off as neatly as it does in a system, in a much larger system where everything's kind of in house. In communities, in the rural communities, it might be, oh, we've got to pass it off over to this hospital, and then they have to get imaging at that system, and then they have to come back to us, but then they need, and it becomes very complicated very quickly, and it also takes up a lot of uh, time. And like I said earlier, in cancer care, time is the biggest thing, the biggest factor that you want to eliminate as much as possible. And it leads to all these barriers for patients and also for the system itself. So it might be an oncologist will be trying to have, they'll want to do their initial consult, but they don't have the PET scan because they can't get in over here and they got to go to this place. And it just snowballs into this huge issue. And so I had maybe what might be considered like some bright ideas, but maybe a little idealistic or too big at that time, but I had a lot of hope for it, and I still do, um, which was essentially to build a relationship with a much larger facility, and that we oftentimes do patient care with, like we'll refer to them pretty frequently. And so being able to create a connection there where we could have sort of, hey, we have these patients, this person's coming to you, so there's more of like a care coordination connection, so we're not doing multiples of the same thing, and the baton's getting passed back and forth much more fluidly. uh, and honestly, it's been really challenging. It's been super challenging, because of the just lack of understanding of what it's like being out in the rural facilities, and really how much how limited the resources are. But I think we're making slower headway. I think the biggest thing that is really missing is having that physician champion. And that again is another challenge, is recruiting physicians out to these rural communities, and having somebody who really who understands the benefit of, and has the time, to be quite honest, to dedicate to building something like this. Um, but I think what we're seeing is that what's been effective is using what we call chronic care management tactics. Um, which is a lot of the work that I do from the telehealth standpoint, which is just calling the patient, checking in, referring to the chart, just staying kind of on top of, okay, you got this coming up. Okay, you got that coming up. How did that go? Oh, did you need help getting transportation to that appointment? And just really kind of building an internal network as well, especially for certain service lines, like for us out in Port Townsend, the um, gynecological cancers. Those always need to have a lot of baton passing, and so being able to have some doctors that we have relationships with and are developing more relationships with, being able to call up, oh, the nurse over there, and being able to advocate for patients more in a direct way. It's been really eye opening just how big those systems are, how small our systems are, and how disconnected that is. So, just still trying to figure out the best way while also maintaining quality care.
As I was listening to you talk about fragmented care, I like the analogy you used of really just waiting for a baton, because it does bring a nice like visualization of like that, like a relay race where like it is time bound, like you can't do anything until you're handed that baton, and then you're able to then race forward and do that treatment. And I almost wondered if like that's like the treatment equivalent of playing the child's game of telephone. Like you're not necessarily getting every piece of information that's needed, and it just can get then um, over time convoluted or even changed in course um, from when the initial message is.
Yeah, absolutely. That's really the biggest issue that we've seen, is that you're relying then on the patient to be the person who's reporting and kind of managing their own care, but at the end of the day they're going through it. And I just feel like on a professional level we need to figure out some better ways of dialoguing and building relationships with these communities, um, and with these bigger health systems, and because ultimately we all benefit when the patient benefits. And I think like that's something that I'm a message that I really try to drive home, is that fragmented care costs all of us. It means repeated tests, it means patients are waiting longer, which leads to more complex care. All of those things become expansively more expensive essentially, when you think about, from a numbers perspective, which oftentimes hospitals do, and these when they're developing policies and things like that. And so being able to say, like, well, if it took this person 6 weeks to get in for this appointment, how is that effective for anybody? Because it's not only going to cost you more, it it's also costing, you know other the facilities more as well. And like, sometimes we have to speak that numbers game, but ultimately it's really about recognizing is what it costs to the patient. There have been times where, like, a patient's traveled out to a facility that was 2 hour the 2.5 hour drive to get to Seattle, and they will be like, oh, well, you weren't scheduled for today, or, oh, we canceled that appointment. And they're like, and these are people who they chose to get to their appointment over, putting heat in their house for that month. And I think people just don't realize that those are the decisions that people are making out in these rural facilities just to get access to the specialists.
I was thinking about streamlined care and how this is kind of the opposite of that, with these complications and just barriers like you were describing, including that fragmented care. And something that came to mind is like, okay, well, like towards the end of the life cycle for like salmon, like they're going back upstream and they're trying to like jump into these different areas, and they're just getting like stopped. And so I just wanted to share that nice little visualization of rural care. Made me think of like, okay, these are salmon swimming upstream.
Right, exactly. That is exactly what it's like. You're going against the current, and the energy that a person or a social worker, or the resources that are expended to go upstream, they do it because the reward is worth it. And that's the same for patients. They're expending all this energy to travel or to get what they need because it's worth it. But I also feel like we could make it so the current isn't so strong, so the barriers aren't so actively pushing back against them.
Well, Jess, can you, pardon me, perhaps just tell us a little bit more about how being an oncology social worker might look different for rural care?
Yeah, so oncology social work in particular, again, I love referencing the one man band. But oncology social work in the rural setting is, you're you're a therapist. You meet with clients for patients for a regular therapy session, and then when you're done with that, you're jumping into, some helping a patient who may need some practical needs, such as food, or transportation support. You jump into that, plus you jump into doing assessments. You're just kind of doing a little bit of everything, or a lot of everything, every day. And so for some people like myself, that is energizing. It feels good to kind of be able to do so many different things and not feel like you're just doing, or pigeonholed, or stuck in one area. But it also can be challenging too, because you do wear so many hats. You might be helping one patient, who is needing help with something pretty substantial, such as housing. And then you're also helping, with run a survivorship group, or run a support group, or a caregiver support group. So you're really kind of doing all of it. Whereas at larger facilities, I mean, granted, I haven't actually been in them, but from what my colleagues tell me who are in those larger facilities, they're kind of like, oh no, I have my lane. I just, that's my thing that I do. And I'm like, what? That feels unheard of to me.
A bit of a circus performer, right? You're breathing fire while also, juggling, or I don't know. That might be a silly then comparison point, but one thing I wanted to just thank you is, for doing that line dance, for being that mama bear. I was going to say, like, well, maybe that's why I kind of thought of that. Oh, it's the salmon swimming upstream, but I wouldn't want you to be that bear that's catching them, because that has a different connotation. But at any point, like, for being that line dancing
Right.
bear.
Yeah, yeah. Well, and I was just going to add, I think something that from the rural perspective that I think you don't see is just how many people live off the grid and how interesting that can be, because you never know what is walking through your door that day. I've had people who live on boats and only come in at certain times of the year, or people that live deep into these mountains who don't have full access to running water. Those are not typically things you see fully in urban communities, and they're not necessarily, they're more set up to provide some support from the urban side of things, but like in these rural facilities, you don't know what's walking in that day. And so being able to be adaptable um, is really a positive thing, and also a really interesting thing too, because you never know who's coming your way.
Well, I wanted to take this time to just voice my appreciation for really highlighting the difficulties and those barriers for rural care, and just the cool work that you're doing with that.
Yeah, well, thank you. And I appreciate you and Dustin being able to provide a platform like this to be able to talk about it and give rural healthcare a voice, because by giving me this opportunity, you're also giving the people that I work with an opportunity to have their stories told, which is so valuable, because I feel like a lot of folks out in these rural communities feel very forgotten about in a lot of ways. And the healthcare system is no different. And so being able to, take the time to kind of explore with me and hear this side of the experience of healthcare, especially not in this big system, what it's like, I appreciate it. It's very valuable.
Thank you for sharing all of your expertise. This has been a really informative conversation.
Yeah, thank you. I appreciate it.
Our podcast will discuss topics related to cancer treatment and the recovery process, including diagnosis, family support, resources, medications, and nutrition. We aspire to have conversations pertinent and relevant to the cancer journey. Thank you for listening to the Sick and Good podcast. We'd like to invite you to connect with us on our social media at Instagram and Facebook accounts. We're also happy to share that we have launched the Sick and Good podcast website, sickandgood.com. This website is a place to read our bios, subscribe to the podcast, listen to full episodes, or read full transcripts, and contact us with your questions or comments. We care about your listener experience and would love to hear from you to keep the conversation going on the topics of cancer and wellness.